Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick, and I'm a physical therapist focused on patients with limb loss and limb difference. Today, we're diving into outcome measures for the limb loss population. If you're listening to this, then more than likely you are keenly aware of the use of outcome measures in physical therapy practice. They're the backbone of goal setting, insurance authorizations, quality of care assessments, and much more. There are countless measures and more being developed every year. That said, we often gravitate to certain measures that we're comfortable with or to tools that are quicker to administer. In this episode, we'll be looking at the intersection of performance-based and patient-reported outcomes and how their combined use can provide greater insight into our patients. And maybe you'll come away with some new tools for the clinic. My guest today is Allison Symsack, a senior research physical therapist with the Geneva Foundation at Walter Reed National Military Medical Center and the Uniformed Services University. She brings over 18 years of experience in amputation and polytrauma rehabilitation, working extensively with wounded warriors and veterans. Allison is also an assistant professor, an active researcher in limb loss and functional outcomes. She's currently working on her PhD, and she also serves as research chair for the APTA Federal Section's Amputation Care Special Interest Group. Allison, thanks for being here.
Yeah, thanks for having me.
All right, let's dive in. First of all, if you don't mind, can you kind of give us a little bit of background kind of on you? How did you kind of get into this population and kind of what spurred your interest?
Sure. So my DPT degree, my Doctor of Physical Therapy degree, was from the University of Miami, where I was able to study under Dr. Bob Gailey, who is not only renowned in his field for amputation, rehabilitation, and prosthetics, but he's an incredible mentor. And the first day I took his class, I knew I was hooked. I wanted to do amputation care. It was not something that I originally thought that I would go into when going to physical therapy school. I was your typical physical therapy student thinking I would do ortho-based sports or, specialize in pediatrics perhaps, but definitely amputation care was not on my radar until I took his class. And he was so enthusiastic and he made it seem such a rewarding and amazing population to work with and also challenging, which really intrigued me. So we kept in touch. I did a bunch of rotations in my clinical time at the university where I was able to work at, one of them was to work with the VA and work with an amputation population and got more experience. And then straight out of school, after I passed my boards, I got my first job as a certified physical therapist at Walter Reed National Military Medical Center. And I've pretty much, for the most part, been there for over 18 years as a treating clinician. It was during the height of our conflicts overseas. So we had a lot of trauma patients. And originally I was stuck into trauma and doing everything that was limb loss to traumatic brain injury to fractures, and you name it, we probably saw it.
Yeah.
And eventually, and then I even did some aquatic therapy for a little while. I got to do inpatient, a lot of neuro, and eventually I kind of found my spot that I really love to work in, which is our military advanced training center, where we primarily work with lower limb loss. And then, after a few years of doing that, I started realizing there's so much more to limb loss besides just being a treating clinician. And I really started looking at the research world. And now I do a little bit more of that.
Gotcha. What is your, obviously, kind of working a little bit in the treating side of things, but your kind of research role as a research physical therapist, kind of lay a little bit of that out for us.
Yeah, that's also something that I was not aware even existed in the physical therapy world. I had been a researcher prior to going to physical therapy school.
Oh.
I took some time doing a research assistant I wanted a job in healthcare, but during the time that I came out of my undergrad, there weren't a ton of jobs available for me with my major and my degree. So I ended up taking a job at NIH doing it as a research assistant. And I got a little bit of experience doing research, but it was not in any way related to rehab. And so when I became a physical therapist, research wasn't something that I immediately was drawn to. But as you become a treating clinician, you start realizing how important research is in your practice. And once I got to a certain level of being that clinician, I realized I really started wanting to look more at research and be involved in it. And so, as a research physical therapist, primarily what I'm able to help with now is creating protocols for research projects and developing them, helping with being the subject matter expertise in understanding the clinical side of building a protocol of what you want to look at in terms of research. I also execute a lot of the administration for a lot of the rehabilitation pieces of the protocol. For instance, collecting a lot of the data and administering a lot of the outcome measures that would go along with collecting that data for whatever research questions we have. I help with recruitment. I also oversee a lot of the study uh, executions that happen for the study to be successful. I'm the primary or principal investigator right now on one of our big projects at Walter Reed. I'm the site principal investigator, and so I oversee all of the regulatory uh, pieces that would go with that in terms of making sure that the study is doing correct by the IRB.
Mm-hmm. Got it. Yeah, you're keeping busy.
Yeah.
What?
It's a very fun side of being a physical therapist, but I'm also a treating clinician, so I still get to treat in the clinic to
Yeah,
keep credentials, and I still get to work with patients every day, so I get kind of the best of both worlds.
yeah, and you get to bring the research elements into practice, which is what we're doing right now. Obviously our topic that we're kind of diving in is talking about performance based and some patient reported kind of outcomes. I first want to kind of just define that for listeners. Let's kind of talk about how would you just kind of briefly define like performance based and patient reported outcome measure.
Sure. So obviously, outcome measures are metrics and a way to really assess someone's progress or their changes or what's happening in that moment with that patient. And so, performance based, the best way to think about a performance based outcome measure is it's more objective. You can see what's happening with the patient, and there's usually a way to score that assessment or measure. It could be time, it could be distance. There's a metric that you're using, whether it's a score or an actual like, scale, to get a score and uh, a final score for that person on the performance based. But the self report is more of what the patient is reporting. I like to think of it as more subjective because it's really coming from their perception of what they believe their score should be. It's really considered more of a survey if you think about it. It's a questionnaire.
Yeah, excellent. That's fantastic. Um, yeah, I mean, I almost want to kind of dive right into this first paper. So through this, we're going to talk about, just for our listeners, we're going to talk about kind of three papers, kind of guide our discussion with this, and looking at kind of the impact of performance-based and these patient-reported outcomes. Allison, when we had kind of an earlier conversation about this, you cited this one particular study by Wong that talked about basically pulling these two things together. Can you kind of tell me about, like, as you read that paper and you got started on thinking about this, kind of walk me through what was going through your mind then?
Yeah, this paper really caught my attention, not just for clinical reasons, but also from the research part of my brain. It was really interesting. So, one of the primary findings that I found extremely intriguing about this study was that the individuals with limb loss, lower limb loss in particular, they had higher balance ability um, when they actually measured them, like performance based, but they actually were falling more often, um, and than those with lower balance abilities. And then there was also this interesting finding that they had that there was a mismatch between the people that were reporting subjectively through the patient reported outcome measures that their balance confidence was not matching what their functional activity level
Mm.
was. So what was observed in the clinic didn't match what their balance confidence was. It was, so the people that were saying, "Oh, I'm not very good at doing these activities. My balance is horrible," and they're reporting that in the outcome measure, they would watch them in the clinic and have them perform a balance activity, and that was completely the opposite of what they observed. And so that
Gotcha.
was just really interesting to me first. And then the article also, really, the end of the article suggests that we really need to, as physical therapists, assess multiple factors when we're looking at these different parts of functional mobility, balance, strength. It's not always going to match, right, what someone feels that they are capable of versus what they actually can do.
Yeah, that's such an interesting kind of like thing to observe. But for those listening, the study we're quoting here is the impact of vascular disease, amputation level, and the mismatch between balance ability and balance confidence in a cross-sectional study of the likelihood of falls among people with limb loss, perception versus reality, by Wong and Chihuri in the American Journal of Physical Medicine and Rehabilitation in 2019. Yeah, I want to kind of go back to this idea that you kind of mentioned that their performance-based measure didn't really line up with the true fall risk, and I think that's for so many different measures that we use. I mean, think about like a Berg balance scale, a functional gait assessment, even walking speed. Some of these things that we are kind of like hallmarks of physical therapy outcome assessment, um, you know, may not tell the whole picture of what's going on. Um,
Exactly. And in physical therapy, obviously, we want to look at the entire person. And we have to remember, too, that these outcome measures are really a snapshot in the clinic, right? At least the performance
yeah.
based ones. And so, how else are we supposed to know how this person is functioning in their home environment? How else are we supposed to know how they're doing in the community? And really, I mean, other than making them wear wearable sensors, which is something that's coming out a lot
Mhm.
in research right now as well. Other than doing that or having a tracker on them, you're really just needing to ask them questions, and it's all self-report. So a lot of these self-reported measures are asking questions about how someone functions in their normal daily activities, and they are reporting on how confident they feel about doing that activity or how well they feel like they can perform that activity. So that gives us at least a little glimpse of what they're doing and how they feel they're performing these activities. But obviously, we need to match it with what they physically can do, and we're doing that in the clinic.
Yeah. I teach a lab where I actually try to get students to intentionally mess up an outcome measure, not in like not measuring it correctly, but trying to influence a patient. Like if they're measuring walking speed, like walking beside
Mm,
them and like trying to speed them up or things like that. Just with it, with the note of saying it's like, okay, we need to be clear about what we're capturing at this particular moment and how that can do. What uh, particular like balance confidence assessment did they do for this study?
They use the activity specific balance confidence scale. A
Okay.
lot of times you will see it in the literature as the ABC scale.
Mhm.
The one they used in this particular study, I believe, is the 5 level version used. It's a 16 question survey. It measures a person's self perception level of confidence performing certain daily activities without falling. So, for instance, an example of a question would be how uh, I can walk around in my house, you know, and then it'll say, you know, most difficulty, least difficulty, no difficulty at all, and this is based on like they can do that activity without falling.
Mhm.
And so that's just an example of the types. And then the activities, obviously, there's a hierarchy. It starts off with something really low, like walking around in your house, and then it goes all the way to something like walking down a steep driveway.
Yeah.
um, and these are things that it's very hard to recreate that in the clinic, depending on your space. Not most clinics don't have that, and so are you going to have somebody walk down that anyways if it's not safe? So you want to know how confident they are doing that activity or how much difficulty they perceive they would have with that activity.
Yeah. I'm just kind of wondering from like a practical standpoint, let's say you have a patient that's in the clinic and you're seeing this mismatch between like, let's say the performance and their self-report. What kind of questions does that bring to mind? What kind of things might you kind of uh,
move to do next with your patient?
Well, obviously it depends on like what are you measuring
Mm-hmm.
with that. Well, for instance, when we talk about this particular article, they were looking specifically at balance, right, and some functional mobility.
Mm-hmm.
But let's say balance. If you're looking at balance and you're using outcome measures specifically looking at falls risk or balance, and you're finding there's a mismatch, you want to look at why necessarily are they having that mismatch. A lot of times and that's why it kind of leads you down this path. Okay, maybe I need to do another functional activity or another performance based measure
Mm-hmm.
because that would actually give me more information. So, a lot of times when I see something like that, it could be something as simple as they're just not putting a lot of, they don't have a lot of single imbalance over their prosthesis, right? And
Mm-hmm.
sometimes if we've done another performance based measure, we could see that, right? There's a lot of things in the amputee mobility predictor that allow us to see that specifically. And if you did that one as well and saw that, you would know, okay, well, now I maybe need to look towards interventions that really focus in on that prosthetic side stability and maybe even strengthening exercises for certain musculature in the hip or the core that would help with that prosthetic balance for the individual. And then working on those for a month and going back and doing the same outcome measures again to see if there's a change.
Yeah. So that study, like you mentioned, was specifically focused on balance. Our other two papers are kind of looking at other areas of kind of assessment. So the next one we're looking at is, again, from Wong. This is walking asymmetry in its relation to patient-reported and performance-based outcome measures in individuals with unilateral lower limb loss. And this was in the journal International Biomechanics in 2022. Yeah, I find that these were kind of, these next two were pretty interesting and kind of how they found it. What would you say were some key takeaways that you see when you're looking at this article?
Yeah, this article, you're right. I liked this article a lot. It was really interesting. They found that really increased gait symmetry, which is like, what one of the main goals that a lot of therapists, but also patients are really aiming for. They really want to have that symmetrical gait, right? But they found that it wasn't associated necessarily with better walking or better balance performance-based outcome measures. Um, they did well. I'm sorry, they did. So let me retract that. They
Yeah.
actually did find that it was associated with better balance and walking performance-based outcome measures. But that's what we expect, right? We expect that with someone who has better balance and walking performance-based outcome measures, that they are going to have an increased gait symmetry. That as physical therapists that work with limb loss and prosthetics, we would expect that. However, what was interesting is that there was no relationship with the patient reported function. So the patient reported outcome measures and the surveys they were giving these individuals did not match up with necessary. There's no correlation between their gait symmetry and their higher level of function or their lower level of function.
Mm-hmm.
So achieving gait symmetry after limb loss, right, seems to be, at least according to this study, was somewhat unrelated to maybe the perception of someone's functional mobility. And that was kind of interesting because maybe it sort of suggested and pulled to a piece in the literature that says um, maybe some of our gait symmetry measurements that we're using
Mm-hmm.
are not necessarily, maybe we don't have the right outcome measures to measure gait symmetry in certain functional things that people are doing. Maybe that's why it's not matching up.
Yeah, that was kind of my takeaway from this too. It was just that it seemed like when you look at something like symmetry, I have an instrumented treadmill at my work. Very, very lucky to have that. And I'm putting patients onto it and looking at different measures of symmetry, whether that's through the ground reaction force, through step length, stance time, all that kind of stuff. And I would almost kind of agree with like the findings of this. It's like very often, they come and see that's like, oh, there's like a huge change in symmetry, and this, or there, there may be a significant presence of asymmetry, but in terms of like them happy with what they're doing, with what they're accomplishing, like
In
a
terms
lot of
of level
times,
of function, right?
yeah,
They're
there's
able
like
to do quite a bit.
exactly. And for us, we're looking at it in a long-term lens that we want to make sure that we're preventing some secondary issues, like potentially like if they're a unilateral amputee, contralateral pain and contralateral injuries, back pain, all these kinds of things. But yeah, that's something, maybe we do need to look at it from a more functional standpoint. As you were reading this article, did that seem to you to like in any way like hinder or like the efficacy of like a patient reported outcome, or is in your mind is it more of a we need to find a performance based measure that reflects this too?
It made me think a little bit about something that I do say a lot to my patients, is that, I talk to them a lot about gait symmetry and the importance of it. And one of the things that comes up in conversation when we're speaking to someone about that is, yes, I know most of the time you're not going to be walking a straight away, right, where you can actually focus on your symmetrical step length or your gait and getting your hip to come forward, all those things that we cue them for in therapy. It's really difficult for someone to find a straightaway where they can practice those things. And honestly, in most normal life, you're not walking these long distances unless you're in a mall or something, exactly, or on a track. Most of our steps that we take during our normal daily life is these short steps and short little pathways in our home, or to and from your door to the mailbox. And it's usually not on flat ground. Most of the world outside of the clinic is not flat, and so those are things I talk to my patients about, because I'm saying, okay, we want to work on the symmetry. I want you to practice it, but it's so that your body can get used to trying to find it in other places, right? When you're taking those short steps to go from your bedroom to the bathroom, when you're going from the doorstep to your mailbox. But is there a functional outcome measure that actually does performance-based record that? No. And so perhaps we do need to take another look at like our performance-based outcome measures and recreate stuff that is going to be a lot more functional than these basic, okay, I'm just looking at the biomechanics and it's just as straight away and it's only for 10 meters.
Yeah, that's right. Yeah.
Or it's it's on a track.
That's right. It's just like perfect little snippets of activity or trying to stuff. Yeah, no, you're absolutely right about that one. All right, I'm going to go ahead and move on to our third one. So this one is by your former mentor, Bob Gailey. So it's a 2012 paper. I'm all in. I have printed off papers.
It's a great article. It's a lot in there.
Yeah. So this one, a lot of people on this one, but it's the application of self-report and performance-based outcome measures to determine functional differences between 4 categories of prosthetic feet. This is in the Journal of Rehabilitation Research and Development, also known as JRRD. So for this one, they were comparing these functional outcomes, not necessarily specifically gait or specifically balance as like the previous one, but really kind of almost using like this variable of these different prosthetic foot categories. Mm-hmm. What did they find?
So it was interesting because the self-report, the thing I took away from it is one of the biggest things I noticed was that the self-report measures were actually unable to detect any differences between the prosthetic feet. And I thought that was really cool because so many times you'll hear prosthetists or PTs talk about function and everything and based on the prosthetic, if we just change the foot. And clearly these are self-reports. So this is what people are, saying is happening in their normal daily lives and function and balance. They're saying it's not making a difference.
The opinion that should matter.
Difference. Yeah. This is all the same. It's the same as when I use this foot versus this foot. And so that, I think that's a big takeaway. The other thing was, one of the other key things was the amputee mobility predictor detected difference in function after receiving gait training, right? This is specific gait training that I'm assuming is based on I think it actually said it was the functional prosthetic gait training that Bob Gailey does. But there was no differences between the prosthetic feet. So therefore, I mean, you could see that, okay, there's a difference because of this gait training, but there wasn't between the feet. So really just showcase that sometimes, we always think, oh, it could be the prosthetic if we just change the prosthetic.
Yeah.
But maybe perhaps really it shows that
it may not be. And this is where report outcome measures can really help in research show, okay, you're not just showing it on a performance based side, but you can also back it up with the self report as well.
Mm-hmm. Yeah. Kind of saying this, that like if patients can't distinguish, or, I mean, obviously they can distinguish, but, if we're not seeing a difference in self-report measures, do you feel like that's like discounting their role in rehab overall?
Not necessarily, right? Because they didn't find differences between the prosthetic feet, but that doesn't necessarily discount that what the person is self-reporting their function is throughout the progression of their rehab.
Mm-hmm.
And so honestly, half of the battle we know as physical therapists, the ones that work in limb loss, is how is that person perceiving their function to be, and what does that lead to in terms of real function? Because we know that people who have low self-esteem, low motivation in therapy, right? They're not going to have the same results necessarily that they outside of the clinic in terms of function, and so the clinic again is a controlled environment, and so these outcome measures are just that snapshot. So we really do need to have those self-report measures because they allow us to at least have a glimpse, even though it's subjective. It's still a glimpse of what's happening and their perception of their function outside of the clinic. And honestly, I mean, if like you were saying, you're looking at their symmetry, you're watching them walk on this treadmill, but if they are reporting that they're doing really high functioning activities outside of the clinic, then you're improving their quality of life if they're being honest in their self-report, right?
Yeah.
And of course that's a whole nother topic that we
Yes.
that we could go into. But if they are actually reporting how they're doing with some of these functional activities, you're talking about quality of life, and that in itself is really what physical therapists, what we aim for, is to improve that. So I
Yeah,
think they do have a place in therapy and in outcomes.
I totally agreed. Yeah, I was kind of baiting you on that one. So, kind of stepping a little bit back in terms of, talking about prosthetic componentry, just in general rehab perspective, how do you feel like outcome data can help even guide our communication as physical therapists with prosthetists?
I think it can be really important for us to help with showcasing and highlighting the needs that a patient might have in terms of their prosthetic needs,
Mhm.
especially when you start to really look at taking pieces apart of the outcome measure. So, for instance, a lot of these outcome measures, if you're familiar with them, are either, if it's performance based, it's a number of tasks. Sometimes it's one task, but sometimes it's a series of tasks.
Mhm.
Um, in the self report, it's a series of questions about different functional tasks or activities that they can or cannot do. And that can be very telling for prosthetists because they may not know to ask those questions. So, we as physical therapists, if we can run those outcome measures, performance based self report, we can then look at them, assess, administer them, assess them, and then go speak to the process. Well, in their outcome measure, it looks like they're having difficulty picking an object off the floor. When we talk to them, it leads to a further discussion. It opens up the question, okay, well, why is that? Is it because their alignment is a certain way and they can't feel like they can balance to lean over to get it? Is it a vestibular issue? Or is it something with their socket and their trim that they just can't even get the motion to get down to the floor? So there are a lot of things that can come out of the discussions that will happen based on the scoring from the outcome measures. And that's how you can start to speak to other clinicians about what the needs are specific to that patient.
Yeah, absolutely. Um, I think over these different studies, in a way, they make some of these subjective reports sound a little bad. I think it's important to note that it's like, these things are responsive. We've kind of alluded to that, but these things are generally responsive, well evidenced, well backed, and so even though I think as we've been looking through these and we've seen that there's some interesting differences and um, things things that we wouldn't expect necessarily, or where it's not going exactly in line with the performance-based measure. It's still telling us information and still is valuable to us. For clinicians who are feeling overwhelmed as they look at different outcome measures, there's a lot. Just even name like the PEQ, the TAPES-R, the PLUS-M, PROMIS measures are constantly developing. There's a whole lot of self-report, and obviously many of the performance-based ones we've mentioned already. I'm just kind of curious, for a listener, do you have kind of like a starting framework that you use or that you would recommend for others as they're trying to develop this?
Yeah. Obviously, I told you a little bit about my background and how I was a treating clinician for so many years, and I knew about outcome measures and I used them, but I really didn't understand the evidence base behind them. I got very, as many PTs do, got set in my ways of what I like to do or what my clinic tended to do, and you follow a lot of the people that you learn from. So if for a therapist to kind of step outside of that box that they're in, or if they're a new therapist and they really just want to get into outcome measures more, I think the first place you have to start is, well, what do you want to measure? Because there are so many out there. And so whether it be balance or it's, functional capacity, or you just want to look at functional mobility, the best thing to do is kind of turn to the literature and see what do you see is in the literature, in the research, in recent literature that's being put out by our subject matter experts and people leading the way in terms of amputee rehabilitation research. And you'll see the same outcome measures come through, right? Because they're reliable, they're measurable, they're being used not only in research, but they're being used in the clinic as the gold standards. And you will see that kind of pop out. And so you're okay, I see that everyone's using the amputee mobility predictor, let's say. Okay, I'm going to start there. And then finding that and say, okay, well, there's got to be a self-report measure that also measures functional mobility. And then go look for that. And then that's how you can match the pair together, and just start there, and then start building your toolbox. And every therapist finds ones that they like to do better than others. A lot of times it has a lot to do with time and space in your clinic, and the tools that you have.
Yeah. I'm going to put you on the spot. Do you have any that are like your go-to, like top 4 or 5?
I'm a little spoiled because I work at Walter Reed, and we have in our military advanced training center, and we have a very nice track that runs around our entire clinic. So when I can, not every patient is able to do a 2-minute walk test, but I really like the 2-minute walk test.
Nice.
For a number of reasons. Not only is it reliable, and it measures functional capacity, right? There's really they can get to a ceiling effect, but it's very hard for them. And then in that case, you would just move to a 6-minute walk test. Right? There's a place to go from there. But I also think it's a great way to assess someone's gait at the same time. So I'm able to run another assessment while I'm actually doing their 2-minute walk test, and seeing how they are. And the great thing about the 2-minute walk test is you can also do it when they're still on crutches or a walker, and you can actually just document that. There's lots of recent documentation that's come out that links the 2-minute walk test that has standards in terms of above knee amputation, below knee amputation, for transtibials, transfemorals amputations. There's data out there now that shows averages. It's comparative, right? The only thing I would say about the 2-minute walk test, though, even though it is one of my favorites, is that however you run it in your clinic, because not everybody has a track. However you run it in your clinic, you need to make sure, and there's a paper on this as well, by Dr. Ignacio Guinard, I believe, that talks about you need to run it the same way every time for consistency. And you need to make sure that your clinicians in your clinic are also running it the same as you, so that it's comparative, right? So that there's the reliability within your clinic, because he went through, I think, various different, it might have been VAs, I can't remember, but I know he went to different locations and everyone was doing the 2-minute walk test differently. So there wasn't a lot of interreliability between clinics, but there was in the interreliability in terms of how each clinician was running it. So that's the only thing about the 2-minute walk test. There is some variability in it, but I think it tells us a lot of information by just running one test. But obviously, not everyone can do a 2-minute walk test. So maybe you have to go back to a 10-meter walk test.
Yeah. I did a number of videos on some outcome measures some years back. 2-minute walk test was one of those. And I believe in that one. And then especially the 10-meter walk test ones, there's so many different definitions. Not every paper even standardizes it the same way, nevertheless, how it's done in the clinic. So that's a good note for that one. Is there a key self-report one that you would more commonly use in the clinic?
Like the activity specific balance confidence scale. I do like that one for balance. There's a lot of things that you can pull out of the activity specific balance confidence scale, the ABC scale, that can really help you with your goals. You can set goals specific to specific things, items in that. It's very helpful. And you can actually pull out specific functional limitations from the way that they answer the question. And so it really can help you not only figure out the limitations and the things you want to do in terms of your plan of care and making it evidence-based by pulling out from that, okay, this is what they're having difficulty with. Then I know the functional limitation. From that functional limitation, I know what exercises I need to do. And then from there, I can set my goals. So it's like you can pull all of that out from just by piecing out the different pieces of that outcome measure. I also really like the prosthetic lower limb user mobility survey, the PlusM. That's also a good one as well. My favorite thing about having to do that is there is definitely a T-score and you have to figure out the scoring. So once you get good at that, once you get good at that, you can, and it only takes a few times to practice it, but once you can figure out the T-score and how to score that properly, that actually does tell you a lot as well.
Yeah. If we're talking about these, and say as you're doing this, just kind of one last example case here, if you're working with a patient, you've used, let's say, activity specific balance confidence scale, and looking at a 2-minute walk test, we're going along with a patient. If you were to see one of those things stop progressing or kind of starting to plateau, what does that trigger for you, or what are you going to start looking at?
There are always other self-report measures that you can lean towards that would be inclusive or higher level, if you will. And if you're not finding anything, then you can also turn to your performance-based, because a lot of the performance-based outcome measures do go into high-level activity.
What would you say is a high-level self-report measure?
I do think a lot of the end questions on that PlusM are pretty high.
Okay.
Some of them ask for some pretty advanced mobility activities. So even some K4s will look at that and be like, "Do I even do that?" And I guess I could do that.
And then so I'm going to lead it to my final question. I always like to kind of end with a patient question or just a patient story, if you will. Can you think of a patient where, as you were doing these outcomes, that it kind of made a really significant impact either for them or for you?
Yes. So actually, it comes back to that first study that we talked about by Wong, because I had a high-level patient, and he was actually involved in a research study, and one of the questionnaires we gave him, part of the protocol, was the ABC. And then, so he came out with 95% balance confidence. And he's a transtibial high functioning K4. So I didn't think anything of it. And I thought, oh, he is pretty active and he does a lot. That's great. He scored really high. He thinks he's amazing. Right? In his daily life. He's amazing.
Yeah.
But then we went and ran the CHAMP. I don't know if you're familiar with that performance-based outcome measure.
Comprehensive.
It's a comprehensive high activities mobility predictor.
Yeah, there it is. Yep.
And it involves a lot of high agility, high mobility and high functioning activities for patients with limb loss. And the first item that they do is a single limb balance. So someone who would have 95% confidence in their balance should be able to do well on that single limb balance. He was not able to hold it for even, I think it was a second, maybe less than a second. I can't remember exactly. It was very short. And he tried twice, as the trial allows, and he was really upset at mostly himself. But the reason I love this story is because it made me look up that article.
Yeah.
Because I mentioned it to another colleague. Oh, this happened today in our research. And they said, have you seen the article by Wong? And so I looked up the article. The other thing that I really liked about, or thought that this story is intriguing and interesting, was that he specifically asked after that, even though it was part of our research, but it wasn't like he was still involved in physical therapy. He went back to his therapist and said, this is what happened when we did these outcome measures. And it really gave him a glimpse of what his perception was versus what he actually is capable of. And he wanted to know more exercises to specifically work on his balance so that it could help him with his gait.
That's awesome.
So,
yeah.
And other things in his life, right? He
Yeah.
was very active. So for 4 weeks, oh no, it was 8 weeks. For 8 weeks, he went back and he worked really hard on certain strengthening activities for his glute med. He worked on a lot of single limb balance dynamic exercises for single limb balance that his therapist gave him. In 8 weeks, he came back and retested him as part of the study, and he was able to hold his single limb balance for 30 seconds in the champ. So, and he still scored
That's really good.
ABC.
That's very good.
Yes,
yeah.
It's very good for a transtibial. For those of you who are not familiar with limb loss, for a transtibial to hold for 30 seconds in that position with their knee up and they're putting all their weight through their prosthesis and their arms crossed, it's very, very difficult. But he really took it to heart. It just shows how outcome measures can not only help therapists change maybe the direction of their plan of care, or it can help influence their clinical decision making for the plan of care, but it really does show how it can help patients motivate them in that specific instance, or help them see what maybe they do need to still work on, even if they're high functioning, or maybe if they're low functioning and they realize they can do more. It can also go the other way too.
Yeah, that's powerful. Allison Symsack, thank you.
You're welcome.